Chapter 11, Airway Management. National EMS Education Standard Competencies. So things that you're required to know for this particular chapter. Airway management, respiration, and artificial ventilation. Applies knowledge, fundamental depth, foundational breadth of upper airway anatomy and physiology to patient assessment and management in order to assure a patent airway. Adequate mechanical ventilation and respiration for patients of all ages. So the focus will be on anatomy and physiology and pathophysiology and techniques and equipments that can be utilized to maintain the airway, ventilate the patient, and keep the respiration process going. So we'll be looking at airway anatomy, airway assessment, techniques of assuring a patent airway. For respiration, we will be looking at the anatomy of the respiratory system, physiology, pathophysiology of respiration, pulmonary ventilation, oxygenation. We need to understand the difference between external, internal, and cellular respiration. Assessment and management of adequate and inadequate respiration and supplemental oxygen therapy. For artificial ventilation, the focus will be on assessment and management of adequate and inadequate ventilation, artificial ventilation, minute ventilation, alveolar ventilation, effect of artificial ventilation on cardiac output. And for the pathophysiology, this will apply comprehensive knowledge of the pathophysiology of respiration and perfusion to patient assessment and management. Introduction. Important steps in caring for a patient include obtaining and maintaining a patent airway, ensuring the patient is breathing adequately. Oxygen reaches body tissues and cells through breathing and circulation. Inhalation, oxygen moves from the atmosphere into the lungs, and this is done through negative pressure, negative intrathoracic pressure. Exhalation, carbon dioxide leaves the body, and this occurs with positive pressure. Anatomy review of the airway. The airway is divided into upper and lower airways. Ventilation is the exchange of air between the lungs and the environment, so it's a mechanical action of breathing. Diaphragm and muscles of the chest wall are responsible for regular rise and fall. So the diaphragm is a skeletal muscle that is very important to the process of ventilation. If the diaphragm is damaged or it's not being stimulated properly, the patient's ventilation will be significantly compromised. And your airway is divided into your upper and lower airway. I need to be familiar with the structures in the upper airway and the structures in the lower airway. Upper airway. Major functions of the upper airway are to warm, filter, and humidify air brought into the body. The pharynx is composed of the nasopharynx, which is the posterior portion of the nose, oropharynx, posterior portion of the mouth, and the laryngopharynx, which is the posterior portion of the throat. Laryngopharynx is the lowest portion of the pharynx. Nasopharynx is the union of facial bones, forms the nasopharynx, and it's divided by the septum, lined with ciliated mucosal membranes, which are present to trap particulate matter. The turbinates are three bony shells extending from the lateral walls of the nose into the nasal passageway. I have the sinuses, which are cavities formed by cranial bones. They also help to trap particulate matter, and they help in resonance in terms of how your voice sounds. Oropharynx, part of the throat found at the posterior of the oral cavity. The epiglottis is a leaf-shaped cartilaginous flap located at the base of the tongue and above the larynx. Combined with the closure of the vocal cords, these actions protect the airway from aspiration during eating and drinking. So the primary function of the epiglottis is to prevent anything that is not air from entering the trachea. Larynx, complete structure formed by many independent cartilaginous structures that all work together. Main laryngeal structure is the thyroid cartilage, also referred to as the Adam's apple. Main laryngeal structure, is the thyroid cartilage. Glottic opening is the narrowest portion of the adult trachea. Lower airway function. Function of the lower airway is to exchange oxygen and carbon dioxide. External boundaries are fourth cervical vertebrae and the xiphoid or xiphoid process. Trachea is a conduit for air entry into the lungs. When the trachea reaches the thoracic cavity, it divides at the level of the carina. The lungs include smaller bronchi, bronchioles, and alveoli. The visceral pleura covers all lung tissue. The parietal pleura lines the thoracic cavity. Each bronchus divides into smaller bronchi, then bronchioles. Thin hollow tubes made of smooth muscle. Smaller bronchioles branch into alveolar ducts that end at the alveolar sacs. Alveoli serve as functional site for exchange of oxygen and carbon dioxide. This is not new information. I would refer you back to your anatomy and physiology chapters. So this is stuff that you should know at this point because you have this exam on Friday. Oxygen diffuses through the lining of the alveoli into the pulmonary capillaries. Surfactant lines the alveoli, and the purpose of surfactant is to make the alveoli pliable or able to recoil properly, or gives the alveoli elasticity. It prevents it from collapsing. So surfactant lines the alveoli. It decreases surface tension and helps keep the alveoli expanded. Alveoli collapse if surfactant is inadequate or alveoli are not inflated, and we call that atelectasis. And without nitrogen in the body is not able to make surfactant. So nitrogen is important to that. And if a patient has too much oxygen in their body, it can wash off the surfactant, or it can reduce the amount of nitrogen that is in the body. If the alveoli collapse, then there is going to be an issue with respiration, and there is more surface area available for bacteria to work inside the lungs. Between the lungs is the mediastinum, which is a very important space. It is surrounded by tough connective tissues. Phrenic nerve innervates the diaphragmatic muscle, allowing it to contract. So the phrenic nerve controls the diaphragm, and it originates between C3 and C5, that cervical Vertebrae number 3 and 5. Between C3 and C5 keeps the diaphragm alive. Now, the physiology of breathing. Respiratory and cardiovascular system work together. It ensures a constant supply of oxygen and nutrients to every cell in the body. That's the main role of these two systems. It ensures carbon dioxide and waste products are removed from every cell in the body. The heart pumps blood to the tissues of the body. Arteries carry oxygenated blood, and we have exceptions to that. Veins carry deoxygenated blood, and there are exceptions. So the pulmonary arteries carry deoxygenated blood, and the pulmonary veins carry oxygenated blood. That's the exceptions. Every cell needs a constant supply of oxygen. Sufficient external ventilation and perfusion are required to deliver adequate oxygen. So time is very important. 0 to 1 minute without proper oxygenation can result in cardiac irritability. 0 to 4, brain damage is not likely at this point, but the brain is going to start to be affected. 4 to 6 minutes without proper oxygenation, brain damage may be possible at this point. Definitely after 6 minutes without proper oxygenation, the patient is going to have a strong possibility of brain damage, and after 10 minutes they may have irreversible brain damage if there is no proper oxygenation to the brain. Ventilation, the process of moving air into and out of the lungs. So ventilation again is the mechanical action of breathing, and it has two phases, inhalation and exhalation. In the inhalation phase, it is active. It's an active phase. In the exhalation phase, it's passive. So inhalation, active muscular part of breathing. Air enters the body through the mouth and nose and moves to the trachea. The diaphragm and intercostal muscles contract at this point. And when the diaphragm contracts, it moves down, and the intercostal muscles cause the rib cage to be pulled up and out, increasing the size of the thoracic cavity, creating a negative pressure within the chest that pulls air in. Lungs fill with air when this occurs. Partial pressure is the amount of gas in the air or dissolved in fluid, and it must be equal. Inspiration is focused on delivering oxygen to the alveoli. Variations in tidal volume, respiratory rate, or both will affect the minute volume. So if the patient has an issue with their ability to move the chest or how fast they are breathing, then the minute volume is going to be affected. Exhalation. Exhalation does not require muscular effort, so it's a passive process. This is a passive process of breathing. Relaxation of the diaphragm and intercostal muscles increases intrapulmonary pressure. So the diaphragm and intercostal muscles relax, the diaphragm moves up, the rib cage moves back in, and this creates an increased intrathoracic pressure or increased intrapulmonary pressure. The diaphragm and intercostal muscles relax, and air is exhaled forcefully via positive pressure. Now, regulation of ventilation. The regulation of ventilation involves a complex series of receptors and feedback loops. Drive to breathe is based on pH changes in the blood and CSF. So the stimulus to breathe comes from the CSF and the brain picking up changes in the pH. If it's too acidic, the respirations will increase. If it's too alkaline, the respirations will slow down. So the body's responding to the central chemoreceptors in the brainstem responds to changes in the pH as a result of too much CO2 or too little CO2 in the body. When oxygen level rises, respiratory center suspends respiration until rising carbon dioxide level stimulates respiratory center. So there has to be a balance. Oxygenation. Oxygenation is a process of loading oxygen molecules onto hemoglobin molecules in the bloodstream. Adequate oxygenation is required for internal respiration to take place. At high altitudes, atmospheric pressure makes it difficult to bring sufficient amounts of oxygen into the body. So pressure changes can affect how a patient breathes in and out. Metabolism. Cells take energy from nutrients through a series of chemical processes. Each cell combines nutrients and oxygen and produces energy and waste products. The process of exchanging oxygen and carbon dioxide occurs via diffusion. External respiration is a process of breathing fresh air into the respiratory system. Hemoglobin molecules pick up fresh oxygen as it crosses the alveolar membrane and transport it to the left side of the heart. And the red blood cell can only hold 4 oxygen molecules. It cannot hold more than that. Internal respiration is the exchange of oxygen and carbon dioxide between the systemic circulatory system and the cells of the body. So you must know the difference between external and internal respiration. When we're talking about respiration, we're talking about gas exchange. Oxygen passes from blood in the capillaries to tissue cells. Once there is glucose and enough oxygen present in the cells, the energy production will be adequate to carry out metabolism. And that type of metabolism is referred to as aerobic metabolism. So the mitochondria of the cells convert glucose into energy in the presence of oxygen. The energy that is formed is ATP and is produced through Krebs cycle and oxidative phosphorylation. If the glucose energy production is low or the oxygen, there's not enough oxygen available to create the ATP that is required, then not enough energy will be produced and the cell is not able to metabolize properly. So it's going to quickly use up whatever energy has been produced at that point, which is insufficient, and you start to get byproducts like lactic acid forming. When enough oxygen is not present, that is referred to as anaerobic metabolism. Make sure you know the difference. Neural control. Primary control comes from the medulla. So the primary control is from the medulla and the pons. The medullary respiratory center control rate, depth, and rhythm of breathing. The pons has a superior and inferior portion. The inferior portion is the apneustic center of the pons, and it is the secondary control center in the medulla. So, sorry, It is a secondary control center if the medulla fails. And the apneustic center is able to create longer periods of inhalation and deeper inhalation, right? So it can lengthen the time of inhalation and it can create deep breathing. The pneumotaxic center will inhibit the apneustic center, and the pneumotaxic center is more specific. It will have specific interactions or specific control, I should say, in the breathing rate, the rate of breathing. So it can control the rate of breathing and it can shorten the inhalation period. So that's the pneumotaxic. The apneustic lengthens the time of inhalation and creates deep breaths. The pneumotaxic focuses more on the rate. It can affect the phrenic nerve and it can also affect the apneustic center. Chemical stimuli. Chemoreceptors. Chemoreceptors affect respiratory rate and depth. Constantly monitor chemical composition of the body fluids. So the chemoreceptors in the carotid bodies and aortic arch measure the amount of carbon dioxide in the arterial blood. So there are chemical receptors found in the carotid bodies and the arch of the aorta. And they respond to the amount of carbon dioxide in the arterial blood. The central chemoreceptors are located adjacent to the respiratory centers in the medulla. The dorsal respiratory group in the medulla is responsible for initiating inspiration. The ventral respiratory group will control the force of breathing. So ventral respiratory group is responsible for motor control of inspiratory and expiratory muscle. So one area initiate, the other controls the force of inhalation and exhalation. So how much muscle is used is the ventral respiratory group. The initiation is the dorsal respiratory group. Pathophysiology of respiration. Disruption of pulmonary ventilation, oxygenation, and respiration will cause immediate effects on the body. So your assessment must be centered around looking for problems with ventilation, oxygenation, and respiration, because these are the three main areas that will be affected in airway management: ventilation, oxygenation, and respiration. Hypoxia, tissues and cells do not get enough oxygen. Patients with COPD have difficulty eliminating carbon dioxide through exhalation. The hypoxic drive stimulates breathing when the arterial oxygen levels fall. So the hypoxic drive is stimulated by low oxygen levels. That's why it's referred to as the hypoxic drive. The primary stimulus for breathing is stimulated by changes in the pH as a result of too much carbon dioxide in the body. Early signs of hypoxia include restlessness, irritability, apprehension, fast heart rate, anxiety. Once hypoxia starts to linger too long, your patient will start to show changes in their mental status, pulse become weak, and cyanosis starts to develop. So cyanosis is not an early sign. Ventilation and perfusion must be matched. So ventilation-perfusion ratio and mismatch. Ventilation and perfusion must be matched to exchange gas by simple diffusion. The result of inadequate perfusion is less oxygen absorption in the bloodstream and less carbon dioxide removal. So at the point that oxygen reaches the alveoli, blood must be in the capillaries that is coming from the right side of the heart, that is deoxygenated to pick up that oxygen that is in the alveoli. If that blood is not able to do that, then it will return to the left side of the heart, deoxygenated, and that can cause problem because the body is now going to retain carbon dioxide. And if the body starts to retain carbon dioxide, it will combine with water and form carbonic acid, and the pH starts to drop. So the pH drops, the CO2 level increases, and the patient develops respiratory acidosis. Factors affecting ventilation. Interruptions to central and peripheral nervous system can occur. Hypercapnia, overall increase of carbon dioxide level in the bloodstream. Trauma to the head and spinal cord that can affect ventilation. Muscular dystrophy can affect ventilation, and bronchoconstriction from allergic reactions. Now, extrinsic factors like trauma and foreign body airway obstruction can also affect ventilation. Respiratory splinting, hyperventilation, which is slow breathing, hyperventilation, which is rapid breathing. Compensate for various abnormal conditions. So patient can develop alkalosis, which is high blood pH, and acidosis, which is low blood pH. And if the pH level and the CO2 level is moving, then you should be thinking about a respiratory type of acidosis or alkalosis. Factors affecting oxygenation and respiration. External factors. Attachment of carbon monoxide molecules can cause false pulse oximetry readings. Internal factors. Conditions that reduce surface area for gas exchange. Medical conditions such as pneumonia, pulmonary edema, and COPD, and a non-functional alveoli. Intrapulmonary shunting. So blood entering the lungs from the right side of the heart bypasses the alveoli and returns to the left side of the heart in an unoxygenated state. Already spoke about that with the mismatch. Respirations, pain and strong emotions, hypoxia, other conditions that affect the cells. These are all things that can interfere with oxygenation and respiration. Circulatory compromise. So if the circulatory system is compromised, this leads to inadequate perfusion. Obstruction of blood flow to individual cells and tissues is typically related to trauma emergencies. Conditions you may encounter that can affect oxygen and respiration include pulmonary embolism, simple or tension pneumothorax, open pneumothorax, hemothorax, hemopneumothorax. These are not new conditions. These are things that you should be familiar with from your EMT level of training. It's not new information. Conditions such as heart failure and cardiac tamponade inhibit the ability of the heart to effectively pump blood out. Hemorrhagic shock, abnormal decrease in blood volume, and vasodilatory shock determined by the size of the blood vessel. So that's a distributive problem. Having an issue with my slide. Hold on a sec. Let me back up a bit. Okay. All right, now acid-base balance. This is disruption by hypoventilation or hyperventilation. 4 main clinical presentation. So a patient can have respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. If the pH, so for respiratory acidosis and alkalosis, you're looking at the pH and the patient's breathing pattern and the amount of CO2 that is being retained or expelled. So if the pH drops and the end-tidal CO2 level is rising, that's respiratory acidosis. If the pH increases and the end-tidal CO2 level is dropping, that's respiratory alkalosis. For metabolic, once we start to talk about metabolic, it means that the kidneys are going to be involved. But we look at the bicarbonate level and the pH. So if the bicarbonate level is low and the pH level is also low, that's metabolic acidosis. If the bicarbonate level is high and the pH level is also high, that's metabolic alkalosis. Treatment for classic hyperventilation syndrome focuses on restoring normal respiratory rate to increase carbon dioxide level. So when a patient is having an emergency, they will have 1 out of the 4 clinical presentations. They can also have mixed presentation. So they can have a respiratory acidosis with a metabolic acidosis. It can happen. Now, patient assessment, airway evaluation. Recognizing adequate breathing is the first step. So it is important for you to know what adequate breathing looks like and what are the things that you will focus on to determine that the patient is breathing adequately. So breathing should appear easy, non-labored. Normal respirations is 12 to 20 breaths per minute for an adult. If it's a pediatric or younger, the patient will be breathing much faster. There must be adequate depth or tidal volume. There must be a regular pattern of inhalation and exhalation. There should be clear and equal bilateral breath sounds. So you're looking at the rate, rhythm, quality, and depth of breathing. Respiratory distress may be the result of upper or lower airway obstruction. Can be as a result of inadequate ventilation, impairment of respiratory muscles, or impairment of the nervous system. Dyspnea is difficulty in respiratory rate, regularity, and effort. Untreated, hypoxia will result in anoxia and death of body cells and tissues. Determine when assessing a patient with respiratory distress. So things that we need to determine when we are assessing a patient with respiratory distress. How is the patient positioned? Is he or she in a tripod position? So what type of position is the patient in? Is the patient experiencing experiencing orthopnea, right? That's difficulty breathing based on position. Is there adequate rise and fall of the chest? Is the patient gasping? What is the color of the skin? Is the skin moist or clammy? Is there flaring of the nares present? Is there breathing through pursed lips? Do you note any retractions? Is the patient using accessory muscles to breathe? Is the patient chest wall moving symmetrically? Is the patient taking a series of quick breaths followed by prolonged exhalation? Labored breathing is a patient with inadequate breathing. So a patient with inadequate breathing may appear to be working hard to breathe. And labored really means you can see the muscles. So you're seeing the sternocleidomastoid, the pectoralis major, and the rectus abdominis. These are the muscles that you're looking at, the muscles in the neck, chest, and abdomen. If you're seeing excessive use of these muscles, it is classified as labored breathing. Signs of inadequate breathing in adult. If we're able to systematically and technically identify what are the things required for a patient to breathe adequate, then anything outside of that would be considered inadequate breathing. So respiratory rate of fewer than 12 breaths per minute or more than 20 breaths per minute. Irregular rhythm, diminished absent or noisy auscultated breath sounds, abnormal breathing, reduced flow of expired air, unequal or inadequate chest expansion. Increased effort of breathing, shallow depth, skin that is pale, cyanotic, cool, mottled, or moist, retractions, staccato speech patterns. All of these things are associated with inadequate breathing. Now, when you identify that your patient is breathing inadequately, then you need to determine whether or not your patient has a ventilation, oxygenation, or respiratory problem. So once you identify, okay, this is inadequate breathing, you need to determine if it is a ventilation, oxygenation, or respiratory problem. That must be identified. And I've said this many times. If your patient is having difficulty breathing and you're able to see chest rise defines respiratory distress. So chest rise define respiratory distress. If a patient has visible chest rise, they cannot be in failure. If the patient has poor chest rise with altered level of consciousness, poor chest rise with changes in LOC defines failure. So it's very important that you know the difference between respiratory distress and respiratory failure. If you're not able to identify that in the field, your treatment is going to be inadequate. Auscultate breath sounds or breathing, that's very important. Feel for ear movement, evaluate for pulsus, paradoxus, not most for pulsus, paradoxus. And really what that is you put your fingers on the radial pulse. If the patient is having extreme difficulty breathing, the pulse is going to disappear when they're breathing in. That's what pulsus paradoxus is. It's not something that is done commonly in the field, but it's something to be aware of. Note protective reflexes of the airway. Now, serious head injuries may result in irregular, ineffective respirations that may or may not have an identifiable pattern. That's ataxic respirations. So ataxic respiration is when a patient has a serious head injury that causes an irregular breathing pattern. So there is no pattern, the identifiable pattern to the breathing. It's irregular. That's ataxic. Cheyne-Stokes breathing or Cheney-Stokes respiration. It is irregular, but a pattern can be identified. Breathing rate goes up, goes down, then there's a pause, it goes up, goes down. So it's irregular, but it is regular. It has a pattern that can be identified. Whether it's Cheyne-Stokes or Cheney-Stokes or ataxic respiration, they are associated with head injury. Agonal gasp is agonal gasp. Patients may appear to take a breath after his or her heart has stopped, or gasp. So they may appear to be gasping because the phrenic nerve is still sending signals to the diaphragm, but it's too slow and it's just not adequate. So agonal gasp is not considered breathing. If present, the heart has stopped and the patient requires CPR. Be vigilant when monitoring the patient's respiratory distress. And I will say again, for you to determine if your patient is in respiratory distress is defined by visible chest rise. Once your patient has visible chest rise and they're having issues with their breathing, it's respiratory distress. Poor or absent chest rise defines failure. And if poor or absent chest rise is absent, you have to be thinking about the patient's level of consciousness. That is a must. Assessment of respiration continued. LOC and skin color are excellent indicators of respiration. Very important point. LOC, skin color. Remember to determine a baseline mental status once possible. Consider proper oxygenation when assessing patients, pulse oximetry, simple, rapid, safe, and non-invasive method to measure hemoglobin saturation. So if you're making a decision to give your patient oxygen, whether it's supplemental or positive pressure, it is very good to know what the pulse ox reading is on room air before you put them on oxygen, especially for your medical patients. So you will be able to establish a baseline and determine if your interventions are working or not. Pulse oximetry, designed to assess only pulsating blood vessels, can be used to monitor oxygenation status, identify deterioration, identify high-risk patients with respiratory conditions, and assess vascular status in orthopedic trauma. Peak expiratory flow measurement helps to evaluate bronchoconstriction, not something that is used much in the States. You will see it being used in the UK. Increasing peak expiratory flow suggests a patient is responding to treatment. Decreasing peak expiratory flow indicates deterioration. So you can do some research on that. Arterial blood gas analysis rely on non-invasive methods of assessing ventilation and oxygenation. It provides the most comprehensive quantitative information about the respiratory system. You're not going to be required to do an arterial blood gas analysis. That's more paramedic and in-hospital not intervention checks. Entitled carbon dioxide assessment, definitely something that's important. So pulse oximetry measures oxygenation. Entitled is going to measure the CO2 level, which is very important to the process of ventilation and perfusion. So it detects the presence of carbon dioxide in exhaled air. Types of monitors include colorimetric, which is based on color changes, digital, which will give a unit or number, and digital and waveform, which is capnography, which it will give you a number and a waveform. Now, colorimetric carbon dioxide detectors provides qualitative information regarding the presence of carbon dioxide in the patient's exhaled breath. So it's based on color changes. Capnometry provides quantitative information because it displays a numeric reading of exhaled carbon dioxide levels. And the capnography combines both numeric and waveform, which is the best method. So this is the gold standard capnographer or capnography, right? Capnographer or capnography, that's a gold standard. So even if you start off with colorimetric or capnometer, then eventually you have to switch to capnography. Device that provides a graphic representation of exhaled carbon dioxide levels. Waveform capnography provides quantitative real-time information regarding the patient's exhaled carbon dioxide level. It is also able to give you a ventilation rate. So it will tell you if the patient is breathing normal. And when it's normal, the pattern, the waveform is going to look like a square. If the waveform start to look long, which I've pointed out before, I think I mentioned this when we were doing the pathophysiology, I mentioned that if it starts to extend out like this, then your patient is breathing too slow. If it starts to get really narrow, like this, then the patient is breathing too fast. And if it starts to have a shark fin pattern, the patient has bronchoconstriction. We went through this before. So it's a very important assessment tool. Now, quantitative waveform capnography, and you have different types of devices. So you have the capnography that is done with the nasal cannula. So it's a nasal cannula, but it has two connection ports. One goes to the oxygen cylinder and the other one goes to the cardiac monitor. And you have the capnography attachment that can be attached to the BVM. So you have the nasal cannula one, and you have the one that can attach to the BVM. So quantitative waveform capnography is recommended method of monitoring initial and ongoing placement of an advanced airway device. Serves as an indicator of effectiveness of chest compressions and the return of spontaneous circulation. It's a very useful tool. Now, opening the airway. To open the airway and assess breathing, the patient needs to be in the supine position. Reposition a patient found in the prone position. So if you're going to do any type of airway management, assessment and management, the ideal position for the patient to be in is a supine position. Head tilt, chin lift maneuver. Position yourself beside the patient's head. Place one hand on the patient's forehead until the patient's head back. Lift the chin upward, bringing the entire lower jaw with it and helping to tilt the head back. And the head tilt chin lift is indicated for a patient with no suspected spinal injury. Now, for your very young pediatric population, we do not put their head completely in the head tilt chin lift position. So we don't want to extend their head too much because the smaller pediatric population, they're top heavy, so their head is bigger than in proportion to the rest of their body. If they lie completely flat, their head can be in a flex position. Their airway is much more narrow in comparison to the adult population. So for the younger pediatric population, it may be a requirement, or it is a requirement, to elevate their shoulders, to get in line with the ears, to place their head in what we call a sniffing position. So the younger pediatric population doesn't get full head extension. Their head is placed in the sniffing position. The jaw thrust maneuver. Use this method if cervical spine injury is suspected. Place fingers behind the lower jaw and move the jaw upward. The tongue jaw lift maneuver is used to open the airway for oropharyngeal suctioning. Place one hand on the forehead, reach into the patient's mouth and hook your first knuckle under the gum line, the incisors or gum line, and pull the mandible up, or pull the lower jaw up. It is not only used for suctioning, it can be used as a technique to assist in passing advanced airway devices into the patient's upper airway. Maintaining the airway. Place the patient in the recovery position if breathing on his or her own at a normal rate with adequate tidal volume. Does not have a traumatic injury. So this is if you have a medical patient that is not fully alert or oriented or responsive, but they're breathing okay. Turn them on their side. Don't put an airway adjunct in their airway, right? If they have chest rise defines distress. You cannot treat distress with positive pressure unless it is severe. Now, suctioning. Suctioning is the first priority. Suction equipment. Portable suction unit provides vacuum pressure and flow to suction the mouth and oropharynx. So you have your handheld suction, fixed suction unit, and you have your portable. Need to be familiar with the type of suction device you're using. Suction unit should be fitted with wide-bore, thick-wall, non-kinking tubing, soft and rigid suction catheters. Soft and flexible is for minimal secretions or places that a rigid suction catheter cannot fit into. Rigid suction catheters are used for large amount of secretions. Suction device must also have a non-breakable, disposable collection bottle. A supply of water should also be available for rinsing the tips of the suction catheters. Suction catheter is a hollow cylindrical device used to remove fluids and secretions from the airway. You have the tonsil tip, Yanko catheter, and you have the soft plastic non-rigid catheter, also referred to as the French or whistle tip catheter. Techniques of suctioning. Steps to operate suction unit. Check unit for proper assembly. Turn on suctioning unit and test to ensure vacuum pressure of more than 300 millimeters of mercury, not less than. Select and attach appropriate catheter to tubing. Limit suctioning time to 15 seconds for an adult, 10 seconds for children, 5 seconds for infant. If the patient has an advanced airway device in, you will not exceed 10 seconds. If you're going to suction the patient's tracheostomy opening, it must be a sterile technique and you must use a flexible suction catheter. Tracheobronchial suctioning of intubated patient. So if the patient has an endotracheal tube, the patient needs to be pre-oxygenated. So pre-oxygenation is essential to keep the pulse oximetry close to 100% or at 100%. Apply suction as the catheter is extracted. If the secretions are too thick, then maybe 2 to 3 mils of saline may need to be squirted to loosen up. May need to be squirted into the endotracheal tube to loosen up the secretions before suctioning. Needs to be, well, let me not go there. Don't exceed 10 seconds. Now, basic airway adjuncts. Oropharyngeal airway prevents the tongue from obstructing the glottis, often using conjunction with the bag mask ventilation device or BVM, bag valve mask. Should be inserted in unresponsive patients with no gag reflex who have a ventilation issue. Nasopharyngeal airway used in patients with intact gag reflex who is unable to maintain an airway and is having ventilation problems. So indicated in patients with altered mental status who will not tolerate an oropharyngeal airway who is having a ventilation problem. Contraindications: severe head injury with blood draining from the nose, potential for basilar skull fracture is present, we don't want to use it. History of fractured nasal bones, meeting with resistance during insertion. And most protocols will now state that if it's a trauma patient, no NPA. Supplemental oxygen. Administered to any patient with potential hypoxia. Oxygen cylinders, check that the cylinder is labeled for medical oxygen. Month and year stamps are important. Should be within date. Liquid oxygen, not commonly used in the pre-hospital setting. Anyway, liquid oxygen, oxygen that is cooled to aqueous state, much larger volume of oxygen can be stored. Containers do not need to be filled as often. Safety considerations. Ensure correct pressure regulator is firmly attached before transport. Puncture or hole in the tank can cause the cylinder to become a deadly missile. The pin indexing system prevents oxygen regulator from being connected to the carbon dioxide cylinder. Each cylinder of a specific gas has a given pattern and number of pins. Safety system for large cylinders is known as the American Standard System. And this is not new information. This is things that you should be familiar with as an EMT. Pressure regulators reduce pressure to a useful range. Two-stage regulator will reduce the pressure first to 700 psi and then to 40 to 70 psi. Then we can titrate at the desired flow rate. Final attachment for delivering gas to patient. Quick connect female fitting that will accept a quick connect male plug from a pressure hose or ventilator or resuscitator. Flow meter that will permit the regulated release of gas measured in liters per minute. Not new information. Flow meters. Pressure compensated flow meter incorporates float ball within tapered calibrated tube. You'll see that more in the hospital setting. Bird and gauge flow meter. Pressure gauge is calibrated to record flow rate. Oops, too fast. Hold on. Operating procedures. Open flow meter to desired flow rate. Confirm flow from the device. Apply oxygen device to the patient and make any necessary adjustments. Monitor the patient's reaction. Disconnect the tubing from flow meter nipple and turn off the cylinder valve when oxygen therapy is complete. And again, operating procedures are things that we should be familiar with. Hazards of supplemental oxygen. Oxygen supports combustion, oxygen toxicity, damage to cellular tissue as a result of excessive oxygen levels in the blood. Tailor oxygen therapy to patient needs and use caution with administration. Oxygen delivery devices. Oxygen delivery equipment used in the field should be limited to non-rebreathing masks, bag mask devices, nasal cannulas. Non-rebreathing mask preferred device in the pre-hospital setting. Contraindications include apnea, poor respiratory effort. All right, I'm waiting on this slide to move forward. There you go. All right. Non-rebreathing mask continued. It's a combination mask and reservoir bag system. Exhaled gas escapes through flapper valve side ports covered by a one-way disc. Ensure that the reservoir bag is full before the mask is placed on the patient. Not new information. Nasal cannulas deliver oxygen through two small tube-like prongs that fit into the patient's nostril. Limited use in the pre-hospital setting, mainly used for the patient who will not tolerate a non-rebreathing mask. Partial rebreathing mask, similar to non-rebreathing mask without a one-way valve. The Venturi mask has a number of attachments to vary the percentage of oxygen delivered. Medium flow device that delivers 24 to 40% oxygen. Not something you will commonly see in the pre-hospital setting because the nasal cannula can be used in the same manner as the Venturi mask. Tracheostomy mask cover the tracheostomy hole, have a strap that goes around the neck. Oxygen humidifiers, usually indicated only for long-term oxygen therapy. So if a patient requires oxygen therapy for a long period of time or extended period of time, then it should be humidified. If the patient has any signs and symptoms of airway burns, oxygen provided should be humidified. If the patient has any signs of an upper or lower respiratory tract infection, humidified oxygen should be given if necessary. Humidified oxygen is not provided in the field. It is done when the patient is in the back of the unit. So in the pre-hospital setting, the oxygen cylinder that is used in the field doesn't have a humidifier attached to it. The patient is given dry oxygen until they get to the back of the unit. Then a humidifier is used at that point if it is required. Assisted and artificial ventilation. A patient who is not breathing needs artificial ventilation and 100% supplemental oxygen or positive pressure ventilation with high flow O2. Irregular breathing pattern requires artificial ventilation. Altered mental status and inadequate minute volume indicates assisted ventilation. So artificial is a patient who is not able to create proper ventilation for themselves. Once you are providing ventilation for that patient, it's artificial. A patient who is breathing, but their minute volume is not adequate will get assisted ventilation, and minute volume can be affected by the patient's chest rise and the rate of their breathing. Treatment options for patients in respiratory distress or failure include assisted ventilation, continuous positive airway pressure, or CPAP. Assisting a patient with ventilation using a bag mask device. I'm not going to focus too much on this. This is if the patient is breathing and you need to breathe for them. The most important thing is to not squeeze the bag when the patient is exhaling. So you have to synchronize with the patient's breathing pattern. After the initial 5 to 10 breaths, slowly adjust the rate and deliver an appropriate tidal volume. Adjust rate and tidal volume to maintain an adequate minute volume. And this table shows the difference between normal ventilation and positive pressure ventilation. Mouth-to-mouth ventilation. Barrier device protects protective plastic barrier placed on the patient's face with one-way valve. Mouth-to-mouth presents the risk of unknown communicable diseases and psychological barriers. Mouth-to-mask ventilation is preferred. Place physical barrier between the rescuer's mouth and the patient's mouth. To increase the oxygen concentration, administer high-flow oxygen at 15 liters per minute through the oxygen inlet valve of the mask. For your bag mask device or BVM, bag valve mask, can deliver only as much volume as you can squeeze out of the bag by hand, most effective when used with supplemental oxygen and a reservoir. The ideal technique is going to be 2-person. Bag mask device components: disposable self-refilling bag, outlet valve, oxygen reservoir, one-way non-jam inlet valve system, transparent face mask. Volume of air to delivered is based on visible chest rise. Bag mask device technique. Typical adult bag mask device holds a much larger volume of air than needed. Quick, forceful delivery of breaths may result in gastric distension. So if the ventilations are too fast or too forceful, they can bypass the trachea and go into the stomach and cause gastric distension. Be conscientious of the rate of delivery of breaths. Pay attention to what you're doing. To use a two-person bag mask device, kneel above the patient's head, maintain the patient's neck in a hyperextended position, open the patient's mouth and suction as needed. Bring lower jaw up to the mask with your last 3 fingers. Not new information. Hold mask in place while your partner squeezes the bag with 2 hands until the patient's chest visibly rises. If you are alone, use the EC clamp method. Observe for gastric distension, changes in compliance of the bag with ventilations, and improvement or deterioration. Manually triggered ventilation devices. Flow-restricted oxygen-powered ventilation devices used to ventilate apneic or hypoventilating patients. So these are devices that, based on the ventilation rate and settings, you put the device on the patient and you press a button and it delivers the ventilations. It can be manually triggered or it can be automatic, where once you enter the settings, you don't have to press anything. It just delivers the ventilation when it is necessary. It has a demand valve triggered by negative pressure generated by inhalation. It allows a single rescuer to use both hands to maintain mask-to-face seal, reduce rescuer fatigue associated with using a bag mask device on extended transport. Not something you will commonly see in the pre-hospital setting. Automatic transport ventilation, ventilators and resuscitators allow variables of ventilation to be precisely set, which include the ventilation rate, tidal volume, and peak inspiratory time. Not gonna go through the steps of using the automatic transport ventilator. As I say, it's not something you're gonna commonly see in the pre-hospital setting, and it takes time to fully understand how to use a ventilator, because you have to work out tidal volume. Patients' tidal volume, you have to work out alveolar minute volume. There's a lot of things that have to be considered and checked and then enter into the settings. So I'm not going to go too much into that. Certainly, if you wish to, you can read up on it. That's something I'm going to spend a lot of time on. All right, now continuous positive airway pressure. Increases pressure in the lungs and it opens collapse alveoli and it pushes more oxygen across the alveolar membrane. It's going to be used mostly for patients who are close to respiratory failure, who have fluid in their lungs, or they are at risk for interference with respiration or alveoli collapse. Desired effect: improve pulmonary compliance and make spontaneous ventilation easier. Indicated for patients experiencing respiratory distress. Come on. All right, just waiting for this slide to move forward. There you go. Back up a little bit. All right. General guidelines for CPAP candidates. Patients should be alert and able to follow commands. There should be obvious signs of moderate to severe respiratory distress after submersion incident, rapid breathing, more than 26 breaths per minute, pulse oximetry reading of less than 90%. Contraindications: if the patient is unresponsive, unable to speak or sit up, or unable to protect their airway, CPAP should not be used. If they're in respiratory arrest or agonal respirations, if there is hypoventilation or hypotension. There is a pneumothorax, chest trauma, closed head injury, facial trauma, or cardiogenic shock. Contraindications for CPAP exist. If there is a tracheostomy, active gastrointestinal bleeding, nausea or vomiting, recent gastrointestinal surgical procedure, inability to properly fit CPAP system, excessive facial hair, or dysmorphic facial features, CPAP is contraindicated. Application of CPAP. Patient exhales against resistance called positive end expirator pressure or PEEP. It maintains pressure in the lungs at the end of exhalation and keeps open alveoli from collapsing. Controlled by manually adjusting PEEP using a manometer or predetermined by fixed setting on the PEEP valve. Most CPAP units are powered by oxygen. Complications of CPAP. Some patients find the CPAP to be claustrophobic. Coach patients through CPAP application, possible to cause a pneumothorax as a result of barotrauma. Increased pressure in the chest cavity can result in hypertension. Now, special considerations. Gastric distension, inflation of patient's stomach with air, likely to occur if excessive pressure is used to inflate the lungs. Pushes diaphragm upward into the chest. Signs of gastric distension include increase in the diameter of the stomach, increasingly distended abdomen, increased resistance to bag mass ventilations. Laryngectomy, tracheostomy, stoma, and tracheostomy tubes. Laryngectomy is surgical procedure in which the larynx is removed. Procedure is performed by making a tracheostomy or creating a stoma. Suctioning of a stoma. Perform suctioning of the patient's stoma with extreme care. Ensure that if you're suctioning the stoma, it's a sterile technique and you will use a flexible suction catheter. Don't exceed 10 seconds. Ventilation of the stoma of the stoma patient. Use mouth to stoma techniques or bag mass device, tracheostomy tubes, plastic tube placed within the tracheostomy site or stoma. For tracheostomy tubes, they require a 15 to 22 millimeter adapter to be compatible with the ventilatory device. Ventilation is accomplished by attaching bag mass device to 15 millimeter adapter on the tracheostomy tube. All this is saying is you can attach a BVM to the tracheostomy tube if it has a 15 millimeter adapter. Dental appliances. Many dental appliances can cause an airway obstruction. Loose dental appliances should be manually removed. Facial bleeding. Control bleeding with direct pressure and suctioning. Facial injuries are also associated with high suspicion of cervical spine injury. When inserting any type of airway device, maintain inline stabilization of the cervical spine. All right, now let's look at the advanced airway equipment. So the first and most fundamental concept that you need to commit to memory is if your basic procedures are working, advance is not necessary. So if your basic airway adjuncts and your BVM device is sufficient, then you don't need to do any advanced airway interventions. You can also maximize your basic stuff. So if a patient has in an OPA, you can put in an NPA to maximize the airway. You can also initiate passive ventilation if necessary. So you can initiate passive ventilation to minimize the risk of gastric distension for patients that you're doing CPR for. And that's simply putting in a basic airway adjunct, putting the patient on high flow oxygen, and allowing the chest compressions to create a negative pressure to pull the oxygen into the lungs. That eliminates the risk of gastric distension and aspiration. Now, as it relates to advanced airway intervention, if you're required to bag a patient for a very long time, the longer you're bagging a patient is the higher the risk for gastric distension. And this is when we will start to consider the use of an advanced airway device, which these devices can reduce that risk. Now, the first device is the King LT Airway. It's latex free, it's a single-use, single-lumen airway, and it is blindly inserted into the esophagus. So basically, the esophagus is sealed, and above the glottic opening is also sealed off, and there is an opening in the middle that we will ventilate the patient through. It helps to maintain patent airway in unresponsive patients who are not breathing spontaneously, right? So patient must be unresponsive and not breathing. There's an error on this slide. So we don't put it in a patient that's breathing spontaneously. There must be an absence of spontaneous breathing. So no gag reflex should be present, and the patient should not be breathing when you're going to use a King LT. And there are two types. I think my signal is going down. Are you able to hear me clearly? If you're hearing me, okay, raise your hand, because it seems as if my signal is dropping. All right. All right, let me continue. All right, now the King LT airway. There are two types of the King LTD and the King LTSD. I think the King LTD is specifically for adult patients, and the King LTSD can be used in some pediatric patients. Now, when you're going to perform advanced airway management, you're going to need someone to assist you at the airway. So you have to have a partner to assist you, and that's separate from EMTs that may be present, right? So ideally, is 3 rescuers you want to be able to do advanced airway procedures. Might not be available all the time, but ideally that's what you want. So somebody has to be maintaining the basic stuff, ventilating the patient properly, keeping that pulse ox close to 100%. And you want to do that for at least, I would say 2 to 4 minutes, closer to the 4 minutes. During that time that the patient is being pre-oxygenated, you should be examining your equipment and preparing your equipment to use the device. Once your equipment is prepared, then you will give instructions to your partner, stop ventilating the patient, and you insert your device. Once the device is inserted, the first breath that you give with that device, your partner should have a stethoscope on the stomach. So that's the first place you want to listen to. Then you listen to once you have confirmed proper placement via long sounds, then you can secure your tube and note your depth, secure your tube. And eventually you will switch over to your colorimetric or capnography or capnometer, and definitive will be capnography. These are things that we will go through when you come in for skills. Not gonna dwell too much on the procedure. Just know that ideally you want at least 3 persons, and in a first world system, you can have up to 4 persons on scene, 2 EMTs, 2 advanced. Now, King LT airway, alternative to bag mask ventilations when a rescue device is required for failed intubation attempt. Contraindication, it does not protect the airway from effects of vomiting and aspiration. So it's a supraglottic device, so it doesn't completely eliminates the risk of aspiration. It should not be used in patients with an intact gag reflex. Complications, it can cause laryngospasm, vomiting, and possible hyperventilation. Trauma may result from improper insertion. Ventilation may be difficult if pharyngeal balloon pushes the epiglottis over the glottic opening. Patient's height and weight will determine the size of the airway. Then you have the laryngeal mask airway. The supreme LMA is the one that is utilized more in the pre-hospital setting. What you're seeing now on the slide is the original LMA. It is designed to provide a conduit for glottic opening from the glottic opening to the ventilation device. Opening of the LMA is right at the glottic opening. Waiting. Waiting on the slide. There's a delay. All right. Let me backtrack. Advantages. Provides better oxygenation. Ventilation does not require continual maintenance of a mask seal. Insertion is easier. Less risk of soft tissue, vocal cord, tracheal wall, and dental trauma. Provides protection from the upper airway secretions. And as I stated previously, the Supreme LMA is the one that is more popular in the pre-hospital setting because the Supreme LMA is more rigid than the original LMA device. Continuing with the LMA or laryngeal mask airway does not provide as much protection against aspiration as does endotracheal intubation. Indication, patient cannot be intubated, ineffective for ventilation of patients requiring high pulmonary pressures, less effective in obese patients. Complications of using the LMA. Regurgitation and subsequent aspiration is possible. Hyperventilation can occur. Equipment for LMA, it comes in 7 sizes based on the patient's weight, consists of a tube and a mask or inflatable cuff. The eye gel is another new one. I'm not sure if it's that popular, but it's being used. The eye gel is designed to create a non-inflatable anatomic seal of the pharyngeal, laryngeal, and perilaryngeal structures. It's much better than the LMA, and it's just as effective as the King L. Color-coded proximal hook rings indicate the size. The Cobra perilaryngeal airway is not a device that is commonly used in the field. You can read up on it. Distal part of the airways are cobra shaped is cobra shaped. It's a supraglottic device with tube for ventilation and circumferential cuff proximal to the distal end. Not very popular in the pre-hospital setting. The cuff damages too easily. Recommended for use only in patients who are not at risk of vomiting. Contraindication include risk of aspiration, massive trauma, cavity, complications if not inserted far enough. Inflation of the cuff may cause the tongue to protrude from the mouth, disrupting an adequate seal. Insertion technique, not going to spend a lot of time on that. It's not a airway device I'll be focusing on too much, but definitely you can read up on it. The combi tube used to be popular, not very popular anymore. Used more in Canada than it is in the US. Combi tube can be inserted blindly into the airway. It's proven to secure the airway and allow for better ventilation than a bag mask device. The tube can be used for ventilation whether it is inserted into the esophagus or the trachea. So it's blind insertion, and depending on the double tube, the double connection port, you can ventilate through the middle or you can ventilate through the tip, depending on where the tip has been inserted. It contains 2 lumens and it accommodates any ventilation device. Indications: it is indicated for airway management of an unresponsive apneic patient with no gag reflex. It cannot be used in pediatric patients who are below the age of 16 years of age. It should be used only for patients 5'7". Can be used on patients below that age group. It should not be used in patients with a known pathologic condition of the esophagus. Continuing with complications, unrecognized displacement into the esophagus is an issue. Use rigorous confirmation protocol. Laryngospasm can occur, vomiting, and possible hypoventilation. Trauma to the pharynx or esophagus from improper insertion technique. Ventilation may be difficult if pharyngeal balloon pushes epiglottis over the glottic opening. Insertion technique: check both cuffs and ensure they hold air. Patient's head should be in neutral position. Forwardly displace the jaw, insert the device, inflate the cuffs. Confirmation of ventilation is critical. Following inflation of the balloons, begin to ventilate the patient. Confirm chest rise and the presence of breath sounds. Slide delay. Foreign body airway obstruction. So that's your airway, your advanced area. And really what we will be focusing on for advanced airway is going to be King LT, LMA, the Supreme LMA, and combi tube and iGel. Foreign body airway obstruction. Foreign body that completely blocks the airway in a patient is a true emergency. Recognition: with a mild airway obstruction, patient can cough forcefully. You may hear wheezing between coughs. Attempt to remove the object manually could force the object farther down into the airway and cause a severe obstruction. And finally, signs of severe obstruction is sudden inability to speak or cough immediately after eating. Person may clutch or grasp his or her throat. The patient is found unresponsive and does not appear to be breathing. Begin CPR with high quality chest compression. That would bring us to the end of the chapter.